Welcome to the presentation on code management for Nursing 456, Module 3, Chapter 10, Code Management. This is the last section for Module 3. Most codes in cardiopulmonary arrest have been known to be filled with panic and pandemonium. So the best options is to prevent, plan for, and practice. And evidence has shown that these options have assisted in decreasing the amount of panic and pandemonium you will see. The more you practice and the more you actually participate, the less panic and pandemonium you will experience. Okay, so you may hear these called a variety of different names. Most of them you will hear Code Blue, Code 99, or Dr. Hart. This would be either cardiac and or respiratory arrest. This is where life-saving resuscitation and intervention is required, needed and required. Basic life support, AED, basic CPR, but in the hospital, we do advanced cardiac life support. Some paramedics are able to facilitate advanced cardiac life support, but in the hospital, we always do advanced cardiac life support as needed. So for a critical thinking challenge, what type of situations commonly lead to a patient coding? What are some of the differences in the situations involving children versus those that involve adults? So rapid response and code teams are now implemented across the country. The Institute of Medicine and the National Institute of Health have recommended that rapid response teams and code teams be at every single facility. There is a special notification system within the organizations, no matter what hospital you're at. The members of the code team may vary, but most of the time you're going to have an ER physician, an ER nurse, and or an ER tech. You're going to have pulmonary respiratory there. You're also going to have the nurse who is taking care of the patient be active on this code team and be available. You are also going to get an ICU charge nurse or an ICU nurse that will report to this code to help guide and facilitate appropriate ACLS care. Between the ER nurse and the ICU nurse, they can actually run the code if there is no physician available, as long as they follow ACLS protocol. Once a physician is available, they are then in charge of the code. But there will be one of those nurses, either the ER or the ICU, will become the lead, and you need to follow their directions. These allow for improved or better patient management, ensuring that the care is done according to advanced cardiac life support standards, and then other healthcare workers can manage the other patients that are not involved in this code. So traffic control is very important. We don't want a lot of onlookers hanging around. I mean, if I get 14 people in a room, am I going to be able to move around? I don't need 14 people in a room. Okay? So as I discussed earlier, the team members, the leader is usually an MD who is skilled in ACLS. Nurses, typically ICU or ER, and the primary nurse. The primary nurse is the patient who is assigned to which nurse. So if that is your patient, you are the primary nurse. Okay? You know the patient. A secondary nurse will give the medications and get equipment from the crash cart. A third nurse is responsible for recording the events. The nursing supervisor, or even if there's not a supervisor, then the nursing manager or charge nurse, provides traffic control and ensures the securing of an ICU bed if needed. Respiratory therapy will show up and they will be in charge of AMBU and assisting with intubation. If there is not an anesthesiologist or an anesthetist that shows up, then the MD is responsible for intubating the patient. And again, respiratory therapy assists with managing the airway and in the intubation. Some places, respiratory therapists are trained and certified to intubate patients. That depends on the healthcare facility and where you are. During the day shift, a lot of times a pharmacist will come, but a lot other times the pharmacist will be preparing medications if they're at the code. Otherwise, a nurse will do that. If there's a chaplain available, they will report. If there's an EKG tech in with the cardiopulmonary group, they will show up to do an EKG. And then, of course, other personnel will show up to help run errands. But again, that supervisor needs to help control traffic. Too many people is just as bad as not enough people, sometimes much worse. So let's discuss the different equipment that you need. Of course, you need a crash cart. You need a backboard. On that crash cart, you have a monitored defibrillator pacemaker. It is all of the above. It can be used as an AED. There's usually a transcutaneous pacemaker available in the ER and in the ICU if that is necessary, rather than the percutaneous pacemaker or external pacemaker. A bag valve device. We call this an AMBU bag. Airway supplies and suction. These are typically available on the crash cart or code cart, but respiratory therapists typically will bring something with them as well. Medications are available in the medication drawers of the code cart. Also, IV bags, IV tubings, and IV needles, catheters, and start kits. All the IV supplies you need are available on a code cart. There's also the availability for a nasogastric tube insertion, because a lot of times we get a lot of gastric distension with an AMBU bag, and that needs to be deflated and prevent aspiration. There's generally a blood pressure cuff, rolling vital sign machine available. You need to have that as well. This actually is a picture of a crash cart. My concern about this crash cart is everything's labeled and you've got your drawers and all that stuff, but there's no defibrillator on top of this crash cart. You actually have two medication boxes on top. These are very old. This is a very old photograph. You will see newer types of equipment where you have lots of clear plastic, fewer drawers, less confusion. You'll also see where they actually have personal protective equipment on the code carts as well these days. Because a lot of times the code will happen in the emergency room waiting area or in the front lobby where there isn't any other PPE, so the carts will have those on there as well. So here are some things that you need to know, and this needs to be a routine that you set up every time you go on a nursing floor or unit. Know where your cart is. Where is it located? How do you unlock it? And what's the unit protocol for checking it? Typically, it is once per shift that it is checked for expiration dates for medications and equipment, and the defibrillator is confirmed that it is functioning properly. The other equipment that you need to make sure is available: oxygen, suction, and like if you're in the ED, do you have the appropriate child-sized equipment? And typically they have a pediatric code card completely separate from an adult code card. So let's talk about the sequencing of events. You will start out with basic life support, CPR. First thing you want to know is, what is the patient's advanced directives or living wills? This is where it's very important for the primary nurse or the nurse that's assigned to care for this patient to be very well of the patient's choices and preferences. Of course, airway should be open. Patients should be breathing. If not, use a mouth to mask or a bag valve device, BVD mask, an AMBU bag with a face mask. Then you want to do circulation next, chest compressions. Trauma patients or cardiac surgery, this doesn't happen very often, but open chest compression does occur, where they will actually crack the chest big enough to get a hand in there and actually go in and hand compress the heart. Most of the time it's external chest compressions though. So let's go into detail a little bit more when we go into the advanced cardiac life support. So airway and breathing, we have a little bit more detail now. So if the patient is really having a breathing issue, our airway management needs to be improved. We can manually ventilate with an AMBU bag and a mask, or with mouth to mask. And you can do that indefinitely. You do not have to intubate a patient. However, it is sometimes more appropriate and convenient and the correct care to intubate a patient. This will actually allow you to isolate and protect the airway while keeping it open, and it allows you the opportunity to deliver high concentrations of oxygen. You are able to deliver high levels, tidal volume. You can protect the airway, you can suction the airway, and there's even some medications that can be administered via the endotracheal tube. So if a patient is laying there in A, representing that with their head straight and the nose is not in a sniffing position, you can see how the airway, the oral pharynx airway, can be blocked off with an unconscious reaction where total relaxation happens. So if you will do the head tilt chin lift, it will actually open the airway. So this is a picture of someone providing mouth to mask via a one-way valve mask device. We want to get oxygen to this patient as quickly as possible. This representation is someone who is AMBUing a patient with a bag valve mask. See how they are squeezing with one hand. The other hand actually has created a C to hold it onto the chin, just below the mouth at the chin with the index finger, over the nose with the thumb, and then you take the last 3 fingers of your hand and you make an E-shaped sign along the jawbone to help do the head tilt chin lift and make a good seal. This photograph shows that once the endotracheal tube is in place and is secured with an appropriate device, then it's secured. You can actually then just use both hands on the AMBU bag to artificially respirate for someone, once that's secured in the appropriate place. This is a photograph of a CO2 detector, and it will go from this blue all the way up to this greenish, yellowish color. And so this is where you detect more than 5% CO2. That means it's in the correct place. This is one of the ways that you will confirm E2 tube placement. So this right here is a physio-controlled defibrillator. It has the capability of being hands-on, hands-free defibrillation. It can sync and do a cardioversion, and it also has the capability of being a pacemaker, an external percutaneous pacemaker for the patient if necessary. So with ACLS, on your primary survey of this patient, you're going to look at airway, breathing, circulation, and early defibrillation. So ABCD, right? You want to early defibrillate, and this is the use of an automatic external defibrillator, an AED, which you have learned how to use in your basic CPR healthcare provider class. With ACLS, you actually have a secondary survey where advanced skills and techniques are used, and you want to do differential diagnoses and correct any underlying issues so that you can halt the progression of patient deterioration and cell death. So as you move from the airway and breathing and you move into the circulation portion, this is where you get into the ACLS and you start talking about large bore IVs. You want to get the biggest IV size into the biggest veins you can. Physician's assistants may insert a central line. An intraosseous cannula can be done if an IV access is difficult to do inside the hospital. Typically they will do a central line, either jugular, subclavian, or femoral. Intraosseous you might find being done pediatrics quite often, in the EMS system, and in the ED. That's where they have a drill that actually will be drilled into either the sternum or the femur to get IV fluids into the marrow and then shifted into the vasculature that way. So we talked about earlier when I was talking about intubating a patient and giving some medications, the medications that you can give via an ET tube, if you remember the acronym ALE, atropine, lidocaine, and epinephrine. You also want to move to defibrillation and differential diagnosis in the ACLS component. So if you are going to defibrillate or have to make sure that you are not touching the patient or the bed, nobody else is, and you have to hold 20 pounds of pressure, 20 to 25 pounds of pressure onto those paddles and push down onto the patient so that it can go through all of the resistance of the skin, muscle, and bone and get as much electricity to the heart muscle as possible. Hands-free pads actually do much better, have less complications, and allows you to not actually be on top of the patient when the electricity goes through. So for hands-free pads, you can use the hands-free pads in the same places that you do the handles, or you can do a frontal posterior patch where it will go with the round one goes on the front, the square one or rectangular one goes on the back, and that actually allows the electricity to go straight through the heart rather than from the atrium down to the ventricle, like when you do the right chest, patient's right chest and left rib cage. That sends the electrical impulse from the right atrium into the left ventricle. But if you do the hands-free and you do anterior-posterior, it actually allows the electrical impulse to go straight from the front to the back of the heart and completely reset all of the electrical cell membrane potassium pump, sodium-potassium pumps. With a woman, you have to be very careful and make sure that you go underneath the breast. Another concern is make sure that you are not having any of the hands-on or hands-free pads and paddles on a nipple anywhere. It will severely traumatize, even cause necrosis, because this electrical impulse will actually burn the skin. So be very careful. This is an actual automated external defibrillator, an AED. If you will turn it on, Then follow the directions of putting the pads on and then plugging the plug into the machine. It will walk you through whatever you need to have done. These are very simplistic, basic equipment that will talk you through what you need to. You must remember when it says not to touch the patient, do not touch the patient, because it will interpret that as a rhythm, whatever activity you're doing, and you don't want it to do that. Okay, so this shows you a natural QRS complex, P, QRS, and T. The little two bars out on that T, that is a danger zone. We do not want to strike our defibrillation on that area, as that will cause an R on T pattern VTAC. So we would prefer it to happen somewhere in the PQR section. Okay? And that really comes to life and is a big concern when you have someone who has a good pattern and you are going to cardiovert. You want to synchronize it so that it will only fire on the R and just make a huge discharge and reset the heart. Okay, so for code management, some critical thinking for you. What site is recommended for IV access during a code, and why? What fluid is administered through the IV line? What is the procedure for drug administration through an endotracheal tube, and which drugs are they that can be given through the endotracheal tube? So this slide gives you a logical flow of the events. You start out with CPR, BLS. Then you move to ACLS and AED. You do an ongoing assessment of the pulse oximetry, any end-tidal CO2, pulse checks, blood gases, lab work. All of those things are ongoing with your assessment, and they're happening at the same time as the ACLS, crowd control, family notification and communication, family presence in the code. Let's talk about that. And then if the code is successful, will the patient stay there? Will they transfer to the ICU? That needs to be evaluated. So some more critical thinking questions. What should be done with other patients when a patient codes, if it's in a semi-private? What about that nurse who's the primary nurse? Who's going to watch her other patients while she's tied up with this situation? What should the other patients be told? What are some strategies you can use when communicating with family members during a code? And what are the issues surrounding family presence during a code? So, in summary, for ACLS, you always want to treat your patient, not the monitor. CPR is done throughout the entire episode. Remember, early defibrillation is essential to saving lives. Use an endotracheal tube for medication administration when needed, and provide your treatments according to ACLS algorithms. So let's talk about dysrhythmia management and the algorithms related to ACLS. Okay, so algorithms, we're talking about early defibrillation, public access to defibrillators, AEDs, highly encouraged. AEDs are used in the field. They're even used in the hospital when it's on a med-surg floor. They can use an AED. A lot of the brand new defibrillators that are used in hospitals have a built-in AED mode. So when an ICU and an ER nurse gets there, they need to remember to swap it to a defibrillator mode. But that capability. This is a Zoll defibrillator cardioversion pacemaker. And so it will do all of the above. It will defibrillate. It will cardiovert. and it will do external pacing. It is small enough, compact enough that it can also be used for transportation. So a lot of the ICU nurses will use this, and ED nurses will use this, as well as cath lab when transporting patients in a very labile situation or unstable situation. This particular defibrillator is actually a Philips, one of the newer Philips. It also gives you the capability of AED, defibrillation, cardioversion, and pacemaking. It gives you also the opportunity for hands-free. And this is the newest model. They're all very user-friendly. Okay, so two rhythms that you really need to be aware of and should be able to rapidly respond to would be VFib and pulseless VTach. These are shock rhythms. So remember, ABCD, airway, breathing, circulation, defibrillate. Initiate your CPR. You want to shock, do CPR, shock, CPR, shock. So 3 shocks. If you have a biphasic defibrillator, which most of the defibrillators inside hospitals now are all biphasic, you can do it at 200. If it's still a monophasic, you want to go to 360 joules of electricity amperage. Okay? You want to do an IV access and give either epinephrine or a dose of vasopressin. If you give a dose of vasopressin, it can be repeated times 1, and you give like 40 milligrams. Epinephrine can be given once every 5 minutes. You want to intubate a patient if you are unable to effectively manage their airway and ventilate that patient. If you are able to do so with an ambu bag and a mask, you can continue to do that until it becomes necessary to intubate a patient. So then once you initially do your 3 shocks, 3 rapid shocks, then you're going to do a drug and then shock, drug and then shock. So if you get epinephrine, you can repeat that. If you give vasopressin, you can only give it once. Consider using some type of antidysrhythmic drug the next time, like amiodarone, which is the first line drug of choice, lidocaine, and pronestal or procainamide. Magnesium is what you want to give if you have a low-level VTach or you have torsades. And then sodium bicarbonate, very rarely will you see sodium bicarbonate to be given. Only if a patient's blood gases show significant acidosis will you see the recommendation for a half or a whole amp of bicarb. The next rhythm we want to talk about is PEA, which is pulseless electrical activity. We used to call this EMD, electric mechanical dissociation. In other words, we have electrical impulses happening, but there's no muscular contraction in response to that electrical impulse. There is a rhythm on the monitor, but there is no heartbeat, no pulsation. So you want to do airway, oxygen, intubate, IV access, ABCD with CPR, and treat the causes of PEA. So you need to be familiar with what those are. And the drugs of choice are epinephrine and atropine for PEA. Do not shock this rhythm. If you have a VTach with no pulse, that is shockable. But if you have sinus brady, sinus rhythm, and you have not, do not shock the rhythm. Do CPR and treat the underlying cause. These are the things that you want to look for: hypoxia, hypovolemia, hypothermia, acidosis, hypo or hyperkalemia. Could this be an overdose? Could this be a tamponade? Could it be a tension pneumo? Or could this be a coronary infarct or a PE? So these are the things that you want to look for. So 5H, 4T. Okay, so now asystole. Again, we want to do ABCD with CPR. Get an airway, get them oxygenated, intubate, IV access. Now with this asystole, you want to confirm it in a second lead, because if it's a fine V-fib, you can shock that. But if it's still asystole, do not defibrillate. Do not shock this. You treat the cause just like PEA. So asystole is typically a PEA issue. Treat the cause. Remember, 5H4T. You can use a transcutaneous pacemaker. You can try to pace a rhythm. You can give this patient epinephrine and atropine, but do not give them any electricity. Okay? Okay, so sinus bradycardia is not a problem unless they're symptomatic. If they have symptomatic bradycardia, you will treat them A, B, C, D, and CPR. Airway, oxygen, IV access. Then give atropine first. Then consider an underlying cause of this symptomatic bradycardia. You may have to give someone transcutaneous or percutaneous pacemaking. If so, if you are using a pacemaker through their skin chest wall, that's going to take a lot of electrical juice, and it's going to be very uncomfortable, so you may need to sedate and give them some analgesics. You may also consider some dopamine or epinephrine to help speed the heart rate up. Do not give lidocaine, because what rhythm you do have, you do not want it to be slowed down anymore. Lidocaine will slow it down. No lidocaine with symptomatic bradycardia, just with V-fib VTAC. Okay? This rhythm shows bradycardia. The patient may be symptomatic. This has elevated STs. There's also a P wave, but look how close it is to the QRS complex. So could this be an AV-initiated rhythm? Absolutely could be, but there is a P wave in front of, even though it's just in front of, and it is in inverted, but there is ST elevations here. So I have to be concerned about this patient having an infarct. What do you think symptomatic bradycardia would be? Symptomatic would be low blood pressure, short of breath, loss of consciousness, weak thready pulse, cyanosis. Those are symptomatic bradycardia. Okay, so if we have a patient who is in SVT and we give them a medication called adenosine, you can see how it's very quick. We give the adenosine and then it slows down significantly. And if it does not recover in a timely fashion, you can come back in a symptomatic bradycardia with this particular medication. So you have to monitor for that. Most of the time patients come back in a bradycardia that lasts very, very shortly, like about 4 or 5 beats, and then they get into a sinus rhythm. I have seen them go back into an SVT, but if they stay in a symptomatic bradycardia, then you want to treat them as if they were symptomatic bradycardia. Unstable VTAC, again, airway, breathing, circulation, and defibrillate. Airway, oxygen, IV access. Identify the tachycardia, the unstable, identify it. Give the patient sedation and then cardiovert. Reassess your patient and the rhythm once your cardioversion has been done, because you want to make sure you get a rhythm back on this patient. And you need to sedate them if it's an unstable tachycardia and they're holding on right now. You want to cardiovert. That means you are going to synchronize and you're going to hold that button and hold the pressure constant until you hear it fire on an R wave. Okay? So this is a cardioversion. This is a synchronized cardioversion. If they have an unstable VTAC where they have lost their pulse or something like that, this is where we have defibrillation. Defibrillation is the primary treatment for VFib and pulseless VTAC. If you are using a monophasic, you want to then use 300 joules. But a biphasic waveform, you want to use 200. And the is an electrical current, and it will shock as soon as you push your two buttons together. It will shock right away. So make sure all patients are all other people are cleared and not touching the bed or the patient or you. So both defibrillation and synchronized cardioversion completely depolarizes the heart. It allows for a resumption of a normal rhythm. But please remember, safety, not just the patient's safety, but everybody else involved and in the room, that their safety, it is essential as well. Complications to cardioversion and defibrillation, you can have skin burns, as these can be significant, and you can have heart muscle damage as well. Defibrillation and synchronized cardioversion can happen with the use of the traditional external paddles, the hands-on paddles, or external hands-off defibrillation multipurpose pads, which it will read an EKG, it will pace, and it will defibrillate. Paddle pad placement is very important. Transverse anterior means that you have patients' left pectoral and right-sided rib cage, that's transverse anterior, it goes transverse to the heart, or anterior posterior, and that's the hands-free piece. You have one pad in the anterior on the chest and one posterior on the back. Okay, there are some internal paddles that can be used, especially on patients who have open heart surgery. These are spoon-type electric paddles that conduct the electricity, but it's at a much smaller electrical jolt because it's directly on the chest. This is when we have open chest CPR or they have cardiac surgery. It's a much lower jolt, and it's direct paddle to heart contact. Another type of cardioverter or defibrillator is an automatic implantable cardioverter defibrillator. This actually will recognize an ectopy and it will deliver a countershock, and it prevents any episodes of cardiac sudden death. So let's talk about the procedure for defibrillation. You want to make sure your paddles or hands-on paddles or hands-off defibrillation pad placement is correct. You want to have good contact with the skin, which will minimize and protect from burns. Remember, those paddles, if you have hands-on paddles, you have to have a conductive medium, even a conductive, it could be a conductive gel, or we have these bright pink gel pads, cardioversion pads that you can put on. Make sure that you charge the defibrillator to the desired ordered setting. You then want to state in very clear and strong voice, I'm clear, you're clear, everyone clear, oxygen clear. You want to make sure that the oxygen is not being touched and being ambushed on the patient while you're going to shock. The other thing is you want to make sure it's not flowing or blowing the oxygen towards the defibrillator pads, because this is an electrical arc. Oxygen feeds electrical arcs into fire. So the oxygen should be flowing away from those electrical pads. So oxygen clear has been added. You want to make sure if you're using the hands-on external paddles, you want to use adequate pressure. You want to shock the patient. Then you want to continue CPR for 2 minutes. Then you can assess the patient's rhythm. Okay? The AED, or automated external defibrillator, does rhythm analysis. It has that capability. It's used for cardiac arrest. You want to place the 2 adhesive pads on there, plug it, you want to turn it on, follow the direction. It tells you to place the pads on the patient and then to take the plug and plug it into the machine. The AED then will patient's rhythm. It will tell you not to touch the patient, and then it will tell you whether a shock is advised or not. And it automatically charges to what it needs to charge to. You just have to push the button when it says to. But you must still say, I'm clear, you're clear, everyone clear, oxygen clear. Because it's the same process. Electrical impulse can have fire. Some key things to remember with cardioversion is it is still electrical current, but you can use a lower amount of joules because the patient is awake. You can start at 50. Remember, it's synchronized for delivery on an R wave and not it actually helps prevent an R on T or a shock on T inducing VTAC, VFib. This also helps disrupt ectopic foci within the cardiomusculature, and it allows the heart to completely reset. So how do you know whether you're going to defibrillate or you're going to cardiovert? Well, here's the difference. If there's no pulse, you need to defibrillate. If they have symptomatic tachycardia and they have a pulse, you can cardiovert them. You can also do what we call an overdrive pacing, where you actually put the external pacemaker on and you crank the heart rate up on the pacemaker and capture their heart rate. And then sometimes you can drive it down as you decrease the rate. You can actually make their heart rate decrease as well. But a physician must be there to guide that direction if you're going to overdrive pace. A transcutaneous pacemaker is an external pacemaker, means it transverses the skin, goes through the skin. It's used for symptomatic bradycardia and for asystolic patients. You use the external pads and in the anterior-posterior placement for pacemaking. You put the pacemaker into demand mode and you adjust the milliamps until you capture a paced rhythm to cause a pacing. Then you want to assess the rhythm for proper functioning. And then you need to sedate and give the patient analgesia as needed, because this is electrical impulses going through them. They're being repeatedly shocked, and it's not very comfortable. So how is defibrillation different for patients who have an implantable cardioverter defibrillator? And how about the one who has a permanent pacemaker? How is defibrillation different for a patient with a permanent pacemaker? Okay, so now let's do a quick overview of your ACLS medications. Let's try to remember that oxygen really is a medication. You have to have a subscription or an order for it. It needs to be administered as ordered, and it must be administered via a licensed person who is trained to do so. That means PCTs, CNAs, and ER techs are not trained to do so. They cannot put patients on it. They can actually put the tubing back on a patient that's taken it off, but they cannot connect it to or disconnect it from the wall, and they cannot adjust the flow meter. It is not within their certified scope of practice. It must be an RN, pharmacist, physician, or respiratory therapist that does this. I think LPNs are able to do it as well. It is used to treat hypoxemia. It is to improve tissue oxygenation. It is delivered by a mouth-to-mask bag valve device, an endotracheal tube, or some other adjunct airway. We can have oral airways with masks, nasal cannula, nasal trumpets, those kinds of things. And during cardiopulmonary arrest, it is always at 100% FiO2 full blast with an ambu bag. Okay, so ventricular lead type medications, ventricular issue drugs. Know the indications, doses, and administration of these medications. Vasopressin, which is used for VFib, pulseless VTAC. Lidocaine is used for any ventricular dysrhythmias. Epinephrine is used for VFib, pulseless VTAC, asystole, and PEA. bradycardia, asystole, and PEA. Dopamine is used for hypotension for cardiac output. Epinephrine is a potent vasoconstrictor. It has both alpha and beta adrenergic effects. It is used for ventricular fibrillation, pulseless VTAC, asystole, and PEA. You can give 1 milligram IV push every 3 to 5 minutes. It is one of the medications that you can be given by ET tube, and epinephrine can be done by continuous IV infusion if needed. Vasopressin is a non-adrenergic vasopressor. It provides intense vasoconstriction when administered at high doses. It may be as effective as epinephrine. The key component here is may be, which is why vasopressin can be used as your first drug rather than epinephrine, but there you have to follow up with epinephrine thereafter, because you can only give one time dose of 40 units IV for VFib or pulseless VTAC. Atropine works by decreasing vagal tone. It is used in symptomatic bradycardia. It also can be given in secondarily in PEA and asystole, but typically is used for symptomatic bradycardia. You can administer a 0.5 milligram to 1 milligram every 3 to 5 minutes IV push to a maximum dose of 0.03 to 0.04 milligrams per kilogram. Typically, it's 2 to 3 doses and that's it. Okay, for asystole, you typically will give a full 1 milligram IV push and repeat every 3 to 5 minutes to a max dose of 0.04 milligrams per kilogram. This is a medication that can be given down the ET tube, and that dose is 2 to 3 milligrams mixed in 10 mils of normal saline. So remember, your ET tube dose is different than your IV dose with asystole. The other thing is make sure your external pacemaker is on standby, because with asystole, you probably are going to want to try to pace them. Lidocaine is an antidysrhythmic medication that is used to suppress ventricular ectopy. You want to give a bolus of 1 to 1.5 milligrams per kilogram. You can actually give an additional bolus of 0.5 to 0.75 milligrams per kilogram every 5 to 10 minutes, up to 3 milligrams per kg. You want to follow that bolus with an infusion of 2 to 4 milligrams a minute. Typically, it is mixed 250 mLs of D5W with 1 gram of lidocaine, so that you get 1 milligram per minute in 15 mils. 2 milligrams would be 30. 3 milligrams would be 45. You want to assess your patient for lidocaine toxicity, and you need to be aware of what the symptomatology is for lidocaine toxicity. Procainamide, or Pronestal, is also an antidysrhythmic. It works by reducing automaticity of ectopic pacemakers. It is used to treat ventricular ectopy and VTAC. You want to give a 20 milligram per minute initial dose bolus and maintenance of 1 to 4 milligrams per minute. You definitely want to monitor for hypotension and any QRS widening, as that is a problem that Pronestal has. It will widen your QRS and delay in the AV node and bundle branch blocks. So you want to monitor for that. Adenosine, or Adenocart, is a drug that slows the conduction of the impulse through the AV node. It's primarily used for paroxysmal supraventricular attack, or paroxysmal SVT. You want to give a rapid IV push through a port nearest the insertion site of the IV. You want to flush very rapidly, forcefully with a 10 ml saline syringe afterwards. Raise the arm. You need to expect a very short pause in their rhythm once it's been administered. The half-life of this medication is 10 seconds with a duration of 1 to 2 minutes. So please be patient. Don't freak out. But if they are not responding back in 2 minutes, then you want to start CPR. Okay? This would be when you would want to give a patient a dose of adenosine here. Verapamil is a calcium channel blocker that is used to slow the conduction electrical impulse through the AV node, but it also has vasodilatory activity. So it will also cause vasodilation. It's used to treat paroxysmal SVT, atrial fib, and atrial flutter. It is contraindicated in PSVT in WPW, Wolff-Parkinson-White syndrome, and I need you to be familiar with what WPW is and what it looks like. Verapamil is given IV bolus. Okay? When I say IV bolus, I mean like push it in like water. Very quick. Diltiazem or cardiazem, it is a calcium channel blocker useful in paroxysmal SVT, especially when it's associated with an atrial fib or an atrial flutter induction. You want to give this IV bolus followed by a continuing infusion. You want to put this, typically it's like 1 to 3, up to 5 and 10 milligrams, depending on how irritated the patient is, and the physician will help guide you in that order. Magnesium is used when there is refractory ventricular fibrillation or a torsades de pointes, which is that twisting of the points, a type of VTAC. If there's a known deficiency in the patient, significantly, you definitely want to do an IV bolus followed by an infusion of titrated by their patient's magnesium levels at intervals. Okay? You want to be careful with your patients. Monitor them for possible tension pneumothorax, as that has been shown that it has caused problems in the past. I have never seen this myself, and I really don't know that it happens very often at all, but you do need to monitor for that. Sodium bicarbonate, again, you only give this medication in the treatment of metabolic acidosis, and the only way to know that is according to arterial blood gas results. And please know that this is very, very rarely given. Dopamine is a vasoactive vasoconstrictor that's used to increase blood pressure. It's used as a continuous drip infusion. Typically, the medication is 5 to 20 micrograms per kilogram per minute. You need to know how to calculate that. The effect is very dose related. A low dose can give you a renal dilatation, a vasodilatation effect first. Dose gives you cardiac effect, and then higher doses of dopamine puts you into vasopressor effects. You need to consider the need for fluids, fluid challenges, fluid boluses versus dopamine on a patient, because if they're dehydrated, dopamine will not work very effectively. Calcium chloride. That actually increases the force of the myocardial and it's used to treat some underlying problem such as hypocalcemia, hypercalcemia, hyperkalemia, or calcium channel blocker toxicity, and it is given IV push only for these kinds of issues. A lot of times calcium chloride, it can be given push very quickly, but I've also seen them give calcium gluconate IV, but not during ACLS. Okay, a lot of times they'll be done during a rapid response to help with that myocardial contraction, especially if it's calcium blocker toxicity. Amiodarone or cortisone is a very unique medication. It works by prolonging the action potential of the muscles, and then it slows a sinus rhythm rate. It's used for ventricular fibrillation and VTAC, refractory to other treatments. It can also be given for atrial fibrillation or atrial flutter to help slow that rate. It's given IV push, and it is followed up with an infusion when needed. Norepinephrine, Levophed, it is a vasopressor. It's a very potent vasoconstrictor, and it's given by continuous infusion anywhere from a half to 30 micrograms a minute. Morphine sulfate is used for ischemic chest pain patients. It's also used in pulmonary edema patients, as it will help increase venous capacitance, or the ability for the venous vasculature to maintain an increasing capacity. So some problems that you can see with ACLS, CPR, those kinds of things. Attention pneumothorax. Air may enter the pleural space, collapsing one full lung. It is considered life-threatening. Cardiac tamponade. This is where fluid builds up within the pericardial sac, and this too is life-threatening, as the heart has no room to contract and relax, so therefore cardiac output suffers. This is a code for any number of hospitals. It was initiated by the Cleveland Clinic Foundation, but it has been adapted for use at a lot of hospitals because of the ease of use and how clear it is. Everything is right there. This is a code sheet, and it allows you to document what medications, what IV fluids, any IV bolus medications, any actual defibrillation, what are your vital signs, saturations, and then any significant events, blood gases, CT, any of that kind of stuff. It gives you plenty of room, and very specific documentation is requested. So for critical thinking questions, why do tension pneumothorax and cardiac tamponade sometimes occur during resuscitation? Good question. How are the problems diagnosed and treated? And if they occur, are outcomes of efforts affected when these things occur? So that code sheet that you saw from the Cleveland Clinic Foundation, it is a document of the event. You need to assign someone to document during the key information would be what time did we start, what actions were taken, what was the patient's response to those. The actions would be defibrillation, medications, pacemakers, intubation, airway management, vital signs, and it also has a place for team members who are present so that they can go back and be questioned on, well, did you work well as a team? What were some of the issues that you remember about the company? Very important to know who was involved in this situation. So after the code, post-resuscitation, the all-consuming overall goals are to optimize patients' tissue perfusion, oxygenation, and to control any dysrhythmias. So the management of the patient's care continues ongoingly. If they're stay there or if they're transferred, that continuation of their care needs to be maintained. So now let's talk about families and supporting the family. Should families be present during a code? What kind of information do you need to provide? What do you think we mean by active communication? If they're not present during the code, or the others that are not present during the code, what kind of communication are you going to encourage after the code? Remember, support needs to come from wherever it's needed: chaplain, emotional support, religious support, and then nursing staff support. So let's talk about, what about if there are other patients that are involved, like in a semi-private room, or if they are down the hall or they've been friends with this person. If there are other patients present, please remove them from that situation. They need to have a conversation. They need to be talked to. You need to assess their feelings and their concerns, and their care needs to be continued without disruption. Some ethical issues to consider: a code versus no code versus a, quote, slow code. What is a slow code? Maybe we should talk about that. Withdrawal of life support after a code. Organ donation. All of these things are ethical issues and things of concern that need to be addressed. And as always, if you have questions, please make sure that you ask. And are you ready for your code sim? It is on Monday. Thank you.